So this slide's going to seem a little crazy by the end, so leave yourself some room. You won't be able to type this. You might have to write it out, just FYI. Because there's some drawing and stuff. So we're going to talk about the emergent phase. So we talked about I'm blanking, pre-hospital phase. Okay, that's everything that happens at the scene. Now, this is what's happening once they kind of get to the hospital. It's 24 to 72 hours after the burn. It begins as soon as we stop the burning process. So as soon as we flush off, as soon as we stop the electrical current, as soon as we, remove them from the flame, as soon as we stop the burning process, we are beginning this phase. And it ends when fluid mobilizes and we begin diuresing. And that's gonna make sense in a second. All right. Your primary concerns during this is, like we said, the shock and edema. With the edema, it's swelling, right? And swelling compromises the airways. And we're going to lose a massive amount of fluid with a burn. So you're at high risk of shock. So the first thing that happens is the burn is going to open the epidermis, right? So just think of this as your skin, and it should go all the way across, but there's an opening because that's where the burn happened. And whenever you have a burn that opens the epidermis, that top layer, it's going to release circulatory factors. So like oxygen-free radicals and all that kind of stuff, right? So it releases these O2 free radicals, and that causes red blood cells to hemolyze, to break open. So if all my red blood cells are breaking open, what's going to happen to my red blood cell count? It's going to go what? Down, right? So I'm going to have low RBCs. And what electrolyte is found within our red blood cells? No? Somebody said it, I just heard it. Potassium, right? So if they're hemolyzing and I'm breaking up all my red blood cells, what's happening? Where's all the potassium going? Out into the blood, right? So what's going to happen to my potassium level? It's going to go high. So what's my patient? Oop, I cheated. What's my patient at risk for? Arrhythmias, right? This is all making sense? So I get a burn, my skin opens, my body's immune system kicks into gear. Those O2 free radicals are sent out to kind of help repair. But those why they're there to help, they kind of damage things along the way. And they break open my red blood cells. So my red blood cell count is low. And I'm releasing potassium, so my potassium level is going to be high. So now I'm at risk for a dysrhythmia. In the meantime, in addition to it, I should say, blisters form, right? We talked about this. Shivering, because we talked about shivering, right? The muscle contraction produces what? Heat, okay? So if my epidermis is my, temperature regulator, and I can't regulate my temperature because I burned that epidermis, I'm going to have to do something else to regulate. So I'm going to shiver, and it's going to probably be painful. Now, depending on the type of burn, if it's a superficial partial thickness, maybe it's just some slight tenderness. Or if it's, a full thickness, maybe I don't have any pain. Or if it's deep partial, then it's very painful, but I'm going to have something on the continuum, right? All right. So then think of this as a blood vessel, and the blood vessel should be like solid, right? It should just be solid down. But what happens is I've got this inflammatory reaction happening. And the inflammatory reaction is increasing my capillary permeability. So think of these little like holes as ways into the blood vessels, ways in and out of the blood vessels. So the blood vessels should just be, you know, if I can find my finger. It should just be like normal, correct? But once that inflammatory reaction happens, then it's kind of like I get like holes along my blood vessel, making it more permeable. Which part are you having trouble with? Number 2?
Parentheses. O2, then top right.
Free radicals. O2 free radicals.
Release what?
Release circulatory factors like O2 free radicals. All right. So I open my epidermis. All those slides that you have in your burn lecture talk about this. But to me, this makes more sense to kind of see what's going on in the body. Okay? So if you don't like it this way, it's all in your slides too. So you've got just superficially what's going on. We've talked about it. Blister, shivering pain. You've got O2 free radicals breaking up red blood cells. Then, after that kind of starts the process, the next thing that happens is this inflammatory reaction. It's making your capillaries more permeable, so things can move in and out of the vascular space more freely. So, fluid, albumin, sodium are moving out. It leaks out. That's why we get the edema, right? Because all this fluid that should be in our blood vessels leaks out of our blood vessels into that tissue. And we get super swollen. That's why that guy with the face looks so swollen. Because that's what's happening. Because when albumin goes, what follows? Water, right? So you have water that's leaking out already, and then albumin starts to leak out, and more fluid shifts out. So fluid leaks out, albumin, sodium. So what does that cause? That causes the third spacing. And this is a massive shift. This is not like, oh, I'm a little edematous. It's like that picture we saw of that kid or guy or whatever. You know, it's a massive fluid shift that happens quickly. Obviously, if the fluid's all in the tissues, where is it not? These are questions, everyone. This is interactive. Yes, thank you. It's not in the vascular space, so your vascular volume decreases significantly. And then if albumin's rushing out, what happens to your albumin? Drops, right? Decrease vascular albumin. So the third spacing, it causes the edema. But where, besides the tissues, where does that fluid leak into? The lungs, right? When we talk about fluid shifting and we worry about fluid overload into the lungs. So it's going to cause obstruction or ARDS, which you're going to talk about in level 4, which is acute respiratory distress or adult respiratory distress syndrome, or pneumonia. But basically your alveoli, those nice pretty alveoli that should be able to exchange the oxygen and CO2 all nicely, are all going to be filled with fluid, okay? Because that fluid is shifting from inside. Because remember I talked with you guys. Oh, maybe it was my process class. I'm sorry. Those are your alveoli, right? In your lungs. This right here is your alveoli, okay? And this is the capillary. So alveoli is the end of your airways. And what happens is when blood goes from your heart and it goes to your lungs, it comes in here and it's going to give off CO2 and collect O2 to go back to the heart, to go back to the rest of the body, right? That's where that gas exchange happens. But if this blood vessel is now all holy, not like holy, but you know what I mean, like has holes, and it's releasing a bunch of fluid, where is that fluid going into? My alveoli, right? So now my alveoli are filling with fluid. Can I have a gas exchange with oxygen and CO2? No. It's like trying to give someone air underwater. Can you blow air into someone's mouth underwater? No. So that's kind of what's happening there. So you're basically drowning in fluid. If I have low volume, the less volume I have, what's going to happen to the viscosity of my blood? It's going to get thicker, right? So I have increased blood viscosity. Does thick blood get out to all the extremities like normal blood does? No. So I'm going to have impaired circulation. Or it's either going to be impaired or just completely occluded. So occluded capillaries leading to necrosis. And this is not just, when we talk about impaired circulation, we think of like checking pulse, right? Or checking cap refill. It's not just circulation to the peripheral, to like your extremities. It's also circulation to things like your kidneys and to your gut, right? So if your kidneys aren't getting blood because it's impaired, are they going to work as well? No. So myoglobin breaks down because the kidneys aren't working, functioning the same. And they occlude the renal tubulars. And that causes renal ischemia, which what's going to happen to urine output? Decrease, right?
What's 18?
Acute tubular necrosis. It's a renal condition. It's damage within the kidneys themselves because they're not getting good circulation. So you don't have enough volume. So the volume you have is thick. And with not enough volume, what happens to your blood pressure?
Not enough.
Yep, not enough. It decreases. Thank you for those choosing to interact. What happened? So what's going to happen to your heart rate in compensation? It's going to increase, right? Because it's all about the cardiac output, right? What do you guys remember what cardiac output is?
Stroke volume times
Heart rate, right? Okay. So if stroke volume is the amount of volume being pumped out, and we always want the cardiac output to stay the same. So if something's affecting my stroke volume and it's going down, what does my heart rate have to do in order to keep it, right? So we always have to have that compensatory mechanism. And my urine output, you already said, decrease urine output. Because I have low volume, and I'm having low urine output for two reasons. In general, I don't have enough volume, and I'm having renal damage because my kidneys aren't getting good circulation. because the blood's too thick to get out to everything. And if I don't have a lot of volume, which organs are they going to go to? Heart, brain, lungs, right? They're not going to go to the GI system. It's going to shunt blood away, so decrease blood to the GI because blood wants to go to the heart, to the brain. So peristalsis is going to go down, so your belly's not going to work the same way, and you can develop an ileus. So you're going to have absent bowel sounds. Your gut's not getting blood, and if your gut's not getting blood, it's not going to work. Your gut has to keep moving. It's continuously moving. That's why we always hear bowel sounds. Sometimes it's moving very slow, like in the middle of the night when we haven't eaten in 8 hours. Sometimes it's moving very fast, like right after a meal because it's digesting, but it's always moving. When the gut stops moving, it develops an ileus, and an ileus is when it kind of twists on itself. So if it's not moving, you're not going to hear bowel sounds, and you can't feed them, right? With low albumin, it's going to lead to more third spacing. And we really worry that it's going to cause not just the edema and respiratory, but also cerebral edema. So if we have swelling of the brain because there's fluid, increased fluid, what are we going to see? Clinical manifestations. Yeah, the CNS changes. And I don't know if everyone... I've said this before, but everything in green is kind of your clinical manifestations of what you're going to see. Everything in pink is kind of what's happening. And then I'm going to put how we treat these things individually in blue. Huh? I know. But this is burns. Telling you, this is burns in a slide. If you can understand this, then you understand what's going on with burns. Okay? You won't have to memorize anything. But does this all make sense? Can you think backwards now? All right. So if we have blisters, we need good wound care, right? That's why we do good wound care, because of the blisters. Because that's going to lead to an increased risk of infection. Pain, we need to treat pain. How do we give pain meds? What's the route that we want? IV. Why?
They don't have enough blood in their GI.
Boom! Ooh, I'm a trip. Because I'm getting excited now. Here's the nerd in me coming out, okay? So, they don't have any bowel sounds. They don't have a bowel working right now. We just said that, right? So if I give them PO... is that going to help? Because what if this is, I get IV because it's more severe and it works better. But the big reason is because our gut's not working. So we don't want to give them anything through the gut because it's not working. And also, why wouldn't we give them anything topical? Is it going to absorb the same way? No, because we have a break right now. All right, so we make sure we give it IV. Now, they're at risk for infection. It says morphine or Dilaudid. IV morphine Dilaudid. Just depends on what your patient, what the doc orders. It doesn't matter what, but they typically get a tetanus booster because they have their exposed skin, right? They're at risk for infection. We do use silver to the body. Has anyone ever taken care of a burn patient? You have. So you know what I'm talking about? It's that Silvadene, that thick white paste. It has antibacterial properties in it.
Well, silver doesn't allow bacteria to grow.
Yes. Yep, that antibacterial properties in it.
A lot of surgeries too.
Huh?
A lot of surgical sites too.
Do it.
That do that.
They do the Silvadene on it.
Even like wound vacs, I've seen them with like silver on. It's all silver.
Yes, the silver is what.
Antibacterial.
Yep. We don't do antibiotics. So, just because they're at risk for infection doesn't mean that we're just going to start throwing them on antibiotics. Because we don't want to develop a resistance. Because if they do develop an infection, then we won't be able to treat it. And when they get sick, they're going to get very sick. The only thing we're going to do is we cannot put silver on the face. So we use antibiotic ointment to the face. Only antibiotic ointment. No IV antibiotics. We save the antibiotics for when we actually have an infection.
What is the X with the line over it?
Except.
Okay, so no antibiotics.
Except ointment to the face, yes. So, because they're at risk for cardiac dysrhythmias, are you going to be able to see a cardiac dysrhythmia from the outside? No. Your burn patient that's intubated, that can't speak to you, are they going to be able to tell you, I'm feeling palpitations? No. So how are you going to know? You're going to be doing labs to check the potassium, and you're going to have on an EKG monitor, right? Bless you, bless you. And again, what's our biggest concern? Shock, right? So, they have low volume, so we need to initiate fluid therapy. And that's going to be the Parkland formula. You'll see that slide in your little PowerPoint. NIPS is going to come up at 4:30 today and do Parkland formula with you guys. I also have it in the course. They recorded it for me another semester, and I have it in the course. So if you need to like review it afterwards, it's already posted in there. I'll double check to make sure I took it out of draft mode. So if I have impaired circulation, me as the nurse, what are things I'm going to do? I'm going to make sure I elevate extremities. I'm going to be checking pulses. I'm going to be checking cap refill. Because that's going to be a concern of mine, right? And I already kind of said this. Again, the occluded capillaries, check cap refills, pulses. Bless you. If I'm concerned about edema, third spacing, that compartment syndrome that we talked about with mobility, it can happen with burns. Because the same thing is happening. I have all this, here's my capillary with all the holes in it. And all this fluid is leaking out. And now all my fluid is in that tissue, the interstitial space all around. Eventually, it's going to compress on my capillary. And now I'm going to have this teeny tiny capillary, okay? So it's going to affect the vascular system and cause a compartment syndrome also. So that's why we worry about circumferential burns, because if we have a circumferential burn, a burn that wraps around the body, it can actually, it's almost like putting what are those things that you tie up? A corset. Like a corset, you're like just tightening it too much. That's exactly what I was thinking of. Prevent compartment syndrome. So those 6 P's that we talked about, we're going to be assessing for them, right? The pallor, the paralysis, and the treatment is the fasciotomy. We're going to cut through that muscle to relieve that pressure. So that burn patient that has a compartment, they'll cut into it, and all this fluid is going to leak. They are like wet, hot messes. Or they can get an escarectomy. Escarectomy, it's in the chest. And there's a picture in your slide between the two. So with albumin, we know we're losing albumin, right? So we talked about the third spacing, the low volume, but we have low vascular albumin. How are we going to treat the low albumin? Increase protein, good. What are we not, did you want to say? Or you were just saying hi? Oh, okay. What are we not going to do?
Risk for
Mm-mm.
it's gonna keep
Okay, you're on the right path. So what do we not want to give? No. Oh, it's okay. Well, some people will think, and it's because this is going to be your thinking. They're low albumin, so I'm going to give albumin, right? Are you going to give albumin? Well, you're going to say no because I'm telling you not to, right? But why aren't you giving albumin?
Because it wouldn't bring them back into the water.
It's- okay.
Take out almost like a hypotonic situation, right? Pull it back in.
No.
Because albumin is.
It's going to pull more out. Because remember, I'm having capillary permeability, right? I have leaky capillaries right here. They're leaking everything out. And I'm already losing albumin. And what follows albumin? Water. And that's why I'm hypovolemic. So if I give more albumin, where's that albumin going? Straight out. And what's going to follow it? More water. So I'm going to actually screw my patient and make them worse because I'm going to drop their intravascular volume more and I'm going to make everything here worse. So I need to focus on nutrition and like protein and make sure they're getting 2 times normal. But in this stage, we're very careful with the albumin we give them because we don't want to make the whole situation worse. Okay? Because again, this is what's happening in this emergent phase. Now, when the capillaries stop being leaky, can I give albumin? Heck yeah. All right? But right now is not a good time because it's only going to compound my situation. So that's why it's so important to understand what's happening. So all these slides basically talk about what we just talked about, okay? There's the Parkland formula right there. It's basically telling you how much fluid they're going to get in the first 24 hours. It is the weight in kilograms times the percent of body burned times 4. All right. And then what they do is they give half of that amount in the first 8 hours and the other half in the next 16. And you will need to know how to calculate this. And again, NIPS is going to come up and do problems with you so you can work this out. But you do need to understand how it's... Because the way, remember, during this phase that we're in, this resuscitative phase or emergent phase, it's all about the leaky capillaries, right? And because we're losing fluid, our biggest concern is that if we lose too much fluid, we're going to go into shock. So things that are going to tell us that we are giving good fluid therapy is going to be the urine output. We need at least, yeah, do you see, I'm sorry, which one do you have a question about? You got it?
Oh, I got it, yeah.
Okay. So your urine output needs to be at least 30 mLs per hour. We probably want it closer to the 50 because that means that we're doing a good job resuscitating them. All right? When we give fluid, we only give LR. Why? Well, one, we don't want to give them potassium. You're exactly right, because we don't want to increase potassium anymore. But what did we talk about in the first lecture, or one of the first lectures, about hypo and hypertonic fluids? What do? They cause fluid shifts, right? Do we want any fluid shifts happening right now in or out of the cell? No. So we only want to use LR. And this is all going to be calculated from the time of the burn, and that's going to be important. Because let's say your burn happened at 8 a.m. but you don't start fluids until 12 p.m.? What is your first 8 hours? Does it start at 8 a.m. or 12 p.m.? It starts at 8 a.m. So when you're calculating the amount of fluid to give in the first 8 hours, even though you have them at 12, you're going to be giving all that fluid in 4 hours. Does that make sense? Okay. So those are some important keys to notice. And again, NIPS is going to come up and work some problems with you. And I have the video for you to understand, but it's LR calculated from the time of the burn. They give half in the first 8, the other half in the next 16. And then this is kind of all the stuff we talked about. The escarectomy, like I said, is on the chest. It's with a circumferential burn. They'll actually cut like a square to release that pressure. There's the fasciotomy down along an extremity. Okay. All right, so we're done with that one. That was the big one, guys. The next phase is the acute phase. And that happens with that diuresis. So it's basically what you just said was the end of the other phase is the beginning of this phase. When you start mobilizing all that fluid back to the intravascular space and you start diuresing. So the capillaries aren't leaky anymore. And it ends when the burns are covered with skin grafts or they're healed. So first we had a massive shift out. What do we have now? A massive shift back in, right? So we're going to have electrolyte imbalances, particularly sodium and potassium. You're going to have massive diuresis, and they're at risk for congestive heart failure because they have so much volume coming back in that the heart now has to pump out, right? Which one?
The burns covered with or without?
Burns covered with skin grafts or healed. So if you have this much sodium and this much water, just like we talked about before, and now all of a sudden you have this much volume or water or blood, whatever you're talking about, your sodium never changed, but is your sodium number going to be technically lower in relation to your fluid? Yes. Okay? So you have electrolyte imbalances not because anything's really happening to your electrolytes, but because of that dilutional effect. And your heart, like I said, is getting so much fluid back to it that a lot of times you get congestive heart failure because the heart can't function. It can't pump out all that blood or pump out all that fluid. It's struggling to keep up. Wound care is really big in this stage because first they get the burn and we're like, oh crap, let's stop the burn. Okay, I've stopped the burn. Now we're in that emergent phase and we're like, oh crap, they're losing all this fluid and I just need to make sure that we keep fluid going so that we can keep all these organs working. And now I'm like, oh crap, they have all these wounds that I need to take care of, okay? So our priorities shift as our patient shifts through the process. So during this time, this is when they're at really high risk of getting their infections and becoming septic and dying, okay? So first, they're going to die because they're in a fire. Then they're going to die because they're in shock. Then they're going to die because they're septic. So, the nurse has to be very vigilant. Nutrition is going to be important. They had that large protein loss, right? So we want to give them high protein. Physical therapy, occupational therapy are going to be big, especially if it involves joints, hands, feet. We need to get them involved. And pain management. Again, the big thing that they're at risk for is infection, right? So reverse isolation, good hand washing, sterile when we do dressing changes, no sick visitors, that type of thing. Cardiovascular, it's kind of the same as before. We're worried about electrolyte imbalances like potassium, so they need to stay on their EKG monitor. We need to look for any dysrhythmias. Neuro changes, again, with all this fluid shift, we want to make sure they're not developing any cerebral edema. Musculoskeletal, they develop contractures because does scar tissue work the same as normal tissue? No. So if they have any scars or any burns along anything that moves, which is a lot of our body, right? Then they're at high risk of developing contractures. GI. So we talked about in the last one, they developed that ileus, right? Their belly's not working. Plus, for all patients that are in the hospital, what are they on? I hope not opiates, not all of them. Nope, all patients are on what? Nope. PPIs, H2 blockers. You'll see every single one of your patient. You may have a patient that's not on pain meds. You may have not a patient that's not on whatever. What? You want to ask a question? What? Oh.
It's like because they're sitting around, because I've gotten that a lot with people like in my clinicals.
It's like Zantac and Bronze.
Yeah, PPI is proton pump inhibitors.
Yeah, that's what I was thinking.
Yes. And then H2 blockers or histamine. So anytime you're in a hospital, or all of you in nursing school, when you have high stress levels, the acid in your stomach increases significantly. And that increased acid is going to cause ulcers, right? And what are ulcers? Do they feel good? No, they're super painful, okay? Plus, we already talked about the fact that they had an ileus. Their stomach wasn't working the right way to begin with. So you'll see, when you go to clinical, you will always, when you do meds with your instructor, talk about some kind of H2 blocker or PPI. I can almost guarantee it. Everybody's on them in the hospital. It's one of the first things they put them on. They may not, honestly, you might get patients with no meds except for like some kind of Zantac or Prilosec or something like that. So, right, we talked about the ileus. They might start an ulcer. So as soon as we can, we start feeds. What am I going to need to make sure? If I was worried about an ileus, that the bowel wasn't working, what's the first thing I'm going to do as a nurse? Listen, good. Check for bowel sounds. If they have bowel sounds, I'm going to be like, hey, doc, I've got good bowel sounds. Can we start, maybe they can't eat by mouth because they're intubated and real sick, but I can throw an NG tube down and get feed started. The faster we get the feed started, the less likely they'll develop an ulcer. The faster they're going to get the nutrition they need to heal. The H2 blockers or the PPIs, that's what I was talking about. Endocrine. Especially if they're diabetic, they might develop a glucose intolerance. And again, we worry about things like increased potassium or that dilutional sodium that we talked about. Low sodium, because there's not really that you're losing sodium, but you have so much more fluid that it washes it out. And the protein loss. This is when we can start maybe giving some albumin in addition to making sure that we do diet, high protein, high calorie diet. They're going to need a lot of calories. Their body's in overdrive trying to repair itself, so they need those calories.
Dr. Daniels?
Yes.
I have a question. When will you know when they start shifting over? Will it just be like monitoring the labs? And
They're going to start peeing, and you'll monitor their labs. You'll see edema start decreasing. They're going to start diuresing like heck. I mean, all of a sudden you're going to be begging for 50 cc's an hour, and then you're going to see like 200 cc's. You're going to be like, oh, okay. So you're going to see this fluid start coming out, edema start going down, and then you're going to be checking labs and stuff also. Yeah. All right. So does anyone have any questions about the acute phase? Yes.
Since the fluid is starting to come back, are we gonna treat with a diuretic or anything?
Yeah, you could give them a diuretic if they need it. Yeah. Normally they're gonna kind of diurese on themselves. Themselves. I didn't mean like on themselves.
Right.
But you want to be careful about giving diuretics because they're gonna diurese anyways. Because you don't want to get them too dehydrated. You want to shift them back to dehydration, if that makes sense.
Is there any way to manage so we don't get that heart failure?
You would basically just keep an eye on them. If they started to sound wet, like crackles and that type of stuff, and you notice their urine output should not be where it is, then maybe they need a diuretic to get that fluid off. But if they're diuresing on their own, which is what normally happens, then you're fine.
So the first word of something is
Mobilization.
mobilization.
Mm-hmm.
And it says H2 antagonist.
Antagonist.
And then next to it,
PPI. PPI. Proton pump inhibitors. PPI. And there's an S there, but it's plural. All right. So now I've made it to the rehab phase. So, whew, I saved him from the burning firehouse. I got him to the hospital, and I got them tons of fluid so they didn't develop shock, and I kept my area nice and sterile and clean, and they weren't septic, and I was addressing their pain and their belly and their wounds and all that good stuff, and now they're all healed and ready to go. So my big thing here is when all the burn wounds are healed, I want to make sure they can resume self-care. Pretty much when they came, before they got the burn, they could brush their hair and brush their teeth and do their job. Can they do as much as possible of that after, now that they're all healed and done? They're going to have to deal with things like scar tissue, contractures. We use things like pressure dressings and making sure good range of motion. These patients have to be very vigilant about passive and active range of motion. If they stay in any one position for too long, they're going to develop a contracture, and it's going to get harder or maybe impossible to get full range of motion again. We want to make sure that they have a lot of function, as much function as possible. So again, we want them to be at the level, as close to or at the level that they were prior to the burn. And obviously they're going to need a lot of psychosocial support. They're going to have scars. Maybe they were a nurse and they burn their hands, and they can't work as a nurse anymore because they're, they have contractures or they don't have full movement of their hands anymore. They're going to have to develop a new skill set or find a new way to make money for their family. So there's lots of things that we have to take into account when helping them. Once we make sure that they're okay from all the other stuff that's happening, they have to now live with this lifelong change. Everyone get all of that? That was it. So again, these are just what we talked about. And then pediatric considerations. We're talking about toddlers right now. It's the second leading cause of injuries in toddlers. Remember, they're going to be more affected by these rapid shifts with their fluid electrolytes. They're more sensitive to changes. And we need to just provide anticipatory guidance to their parents. And that's it. Any questions?